All right, welcome back. Today, we're putting on our detective hats to solve a medical puzzle that comes straight from a 2006 residency exam. The case is all about psoriasis, and our mission is to find the one false statement that's hiding among 4 different clues. So, let's get right into it. So, here it is, our central puzzle. The question basically asks, all of the following statements about psoriasis are correct, except. What that means is, one of these 4 statements, A, B, C, or D, is a total imposter. It's a lie. Our job is to work through the science, look at the clinical signs, and figure out which one it is. Our investigation is going to start at the microscopic level, deep down inside our DNA. You'll notice that statements A and B both talk about genetics, specifically these things called HLA antigens. So it only makes sense that we follow the genetic trail first. Okay, clue number 1, statement A. It's telling us there's a strong link between getting psoriasis early in life and having these specific genetic markers. Now, before we can decide if this is true, we have to figure out what on earth HLA antigens even are. The easiest way to think about HLAs is like they're the bouncers for your body's cells. They sit on the surface, checking IDs, making sure only self cells get in. But here's the problem. In autoimmune diseases like psoriasis, this system gets confused. The bouncers start attacking the body's own cells, thinking they're intruders. And that's exactly why understanding these genetic ID cards is so incredibly important. Okay, this right here helps us evaluate our first 2 clues. So HLA-CW6 is our primary suspect. It's the #1 strongest genetic risk factor for the most common type of psoriasis. This makes statement A, which lists CW6, look really, really credible. But statement B, it makes a very specific claim about arthritis. Let's just keep this in the back of our minds as we gather a little more evidence. All right, let's leave the genetics lab for a bit and head over to the clinic. Now we're going to look at the actual physical evidence from statements C and D. We're talking about clinical signs and potential triggers. So clue C brings up something called Auspitz's sign. This is a classic old-school finding in dermatology. The statement claims it's really useful for diagnosis, but that it kind of disappears in certain types of psoriasis. Let's see how doctors actually uncover this clue. This shows the classic 3-step procedure. First, you gently scrape the plaque, and it creates this white, waxy scale. Then you peel that away, and underneath there's this thin little film. And when you remove that final layer, you see these tiny little pinpoint dots of blood. That's Auspice's sign. And here's the key. This is super characteristic of plaque psoriasis, but you won't find it in the moist areas of inverse psoriasis or in pustular psoriasis. So what does that mean? Statement C checks out. It's correct. On to our final clue, which is all about pharmacology. Statement D lists a few pretty common medications and claims they can actually make psoriasis worse. The question is this a known thing? Oh, it most certainly is. In fact, it's so well known that there's a classic mnemonic medical students learn to remember these triggers. LABI. It stands for lithium, antimalarials, beta blockers, and ACE inhibitors. Since statement D lists 3 out of the 4 of these well-known troublemakers, it is a solid fact. So, if C and D are confirmed true, and A is looking really strong, our circle of suspects is getting pretty small. We've examined the genetic code, we've analyzed the clinical signs, and we've checked the pharmacological triggers. The evidence is all in. I think it's time to unmask our imposter and finally solve this puzzle. Based on our investigation, we've basically eliminated A, C, and D. We know they're factual statements about psoriasis, which means the one incorrect claim, the answer to our 2006 exam question, has to be statement B. This is the false statement we've been hunting for. It's the one that claims in psoriatic arthritis, this HLA-DR4 marker is actually more common than HLA-CW6. So let's break down exactly why that's wrong. So here's why it's incorrect, and this is the crucial part. First off, like we saw earlier, HLA-CW6 is king. It's the most dominant genetic marker, period, across the board. Second, the statement really overplays the role of HLA-DR4. And finally, when you're talking specifically about psoriatic arthritis, another marker, HLA-B27, is a much more classic suspect, especially when the spine gets involved. So the claim that DR4 is more frequent than CW6, it's just not supported by the evidence. Case closed. So we did it. But, solving the puzzle isn't really the end of the story. Now we can take all those pieces we uncovered and put them together to create a complete picture of psoriasis and really understand why this knowledge is so important for patients. And this is a huge takeaway. Psoriasis is not just skin deep. For about 30% of patients, that inflammation goes beyond the skin and starts to affect the joints, which leads to psoriatic arthritis. This just goes to show you, it's a systemic condition and it needs to be monitored very closely. So let's recap our case file. The number one genetic marker to remember is HLA-CW6. That classic clinical clue is Auspitz sign. You always have to be mindful of those LABI trigger drugs. And of course, the big lie we uncovered was the one that overstated the role of HLA-DR4 in psoriatic arthritis. These are the core facts we pulled out from our 2006 case. To really understand the human impact of this disease, just look at this quote from Winston Churchill. He had severe psoriasis his whole life, and he actually said this. It really underlines the profound, life-altering effect this condition can have on someone. And that brings us to our final thought. We've come so far. We've cracked the genetic code. We've mapped the immune pathways. Modern therapies can clear people's skin almost completely. So what do you think is that final barrier? What's standing between us and a true definitive cure? It's a really fascinating question for the future of medicine. Thanks so much for joining me on this one.